over Zoom in various ways over the holiday. So that's tomorrow at 10:30. The links are on our webpage. They also went on email today. So thank you all for bearing with us as we figure these things out. Okay, I want to introduce our guest. Our guest is a special guest today to lead off things is Horatio Kemeny. Last week the last time we met, we had someone who was a native of Vancouver but was living in New York and had experience with the World Health Organization and with the World Bank and all sorts of other places, but wasn't terribly local. Well, Horatio is an extremely local individual. He lives here in Vancouver, if I'm not mistaken. He's a member at Temple Shalom, and he is also someone who has gained. He by profession he is in software development, and he has a background in mathematics and computers. And he on one of his posts he described himself as someone who knows math and who has expertise in computers, and he's not by any means an epidemiologist. However, I think what really drew me to inviting Horatio to start off this week's COVID update is he's someone who's really taken the knowledge into his own hands and has looked at our situation here in Vancouver in a very active way, and he's compared it to other places in the world. So the first question I'm going to ask Horatio is, can you line us up with the rest of the world, the places who are doing it well, the places who have been doing it poorly? Where do we sit, and what is our, help us align ourselves to all the other curves that everyone's trying to flatten at once. I should also just say that I'm going to keep my eye on the chat. People want to ask questions of Horatio, please send them to me in the chat on the Zoom function, and I will be happy to try and get as many questions in as I can.
Sure, thanks for having me. Thanks for inviting me. Well, to answer your question, what started me on this initially was a chart that went around about a month ago. March 17th was the first post that I did. And what it was a chart that was comparing Italy to the US and showing that Italy, at that point, Italy was about 10 days ahead of what the US was tracking as far as new infections were concerned. And that if the US kept up what they were doing, they were going to head down that same path. And I noticed that Canada was easily mappable onto that chart as well. We were about 8 days behind what the US was doing at that time. In fact, I'm going to share that screen and show you a quick look at what it is that got me into this, that interesting. This graph is relatively up to date, but as you can see, for a while here—
Wait, Horatio, you're not shared at the moment.
I'm not shared. Sorry, I'm so new at this computer stuff, you know?
That's a joke.
Yeah.
Okay, here we go.
Let's try that again. You see that?
All right, there, yes, excellent. Okay.
Right. So this chart down here, at the time I started charting this was all a big clump down here. And I offset the data so that the US and Italy and Canada would all be sort of in lockstep, so that, you know, today they all had 100 cases and the next day they all had 180 and then they all had 290. What's it going to look like to see how our response is going to look different to what the Italy or what the US did? With the benefit of hindsight, we can see what happened here for a while here, and it's very hard to see on this graph, but Canada was slowly starting to ramp up at the exact same velocity as the US. And as we all know, at some point, the US response went very wrong. Ours comparatively has been a lot better, to the extent that this graph has sort of become useless now, because unfortunately, the extent of infections in the US is compressing this graph to the point where you can't really see anything down here. At some point, it was, you know, Italy was ahead of where the US was comparatively. And right around the time that Italy started flattening their curve, the US just shot right through it and has never looked back. Once this is not the proper way to be graphing exponential growth. So in fact, here on the right is a comparative. Actually, I'm going to flip over to today's. If you look at these graphs, the one on the right here, you can see, I can't see it because it's blocked, so just a sec. Okay.
We see it. If you're talking about TTD 2, 3, 5, 10
for the
world, yeah, that we see
on
that.
the right shows you the thick red line is Canada. So comparatively, the black line that you see is South Korea, which I put on here as a reference because it's been by far the best example. Its response, as you can see, like right out of the gate, they had a lot more cases because they were doing a lot more testing. And the methods that they used to sort of clamp down on who's got it and isolating them and more testing let them get control of the situation in what was for then and sort of continues to be the model for the world. The interesting thing about graphing exponential data on a logarithmic graph, and logarithmic graphs, as you can see, the scale gets squished down the bigger the numbers get. And the interesting result of that is that what look like expanding curves that go up, as we saw over here, this big US curve over here, as you can see, it starts flattening out because what we're seeing, let me back up a step. These dotted lines that we see here would themselves be exponential lines for something that, in this example, this is a time to double of 2. So what that means is if you are tracking along this line right here, your percentage increase in this case of new infections would be doubling every day. So the flatter that these lines are, the more they're trending to the right, the more they're bending to the right. This line here is a time to double of 2. This one is 3, this one is 5, and this one is 10. You can see that South Korea, if you were to extend this graph way out there, its time to double is already north of a month. And if you look at some of the numbers that we're looking at around here these days, this is encouraging. You know, if I scroll up here, this is not that long ago. At the end of March, here in BC, we were at 4.4%. We're at less than half that right now. And if you back up a couple of weeks from there, we're in the 20s. You know, a 20% time to double, you know, for those of us that were getting good interest rates in the 80s will remember that you don't need a very high interest rate for your money to start really working for you. In this case, it's the exact opposite. That's what we don't want to see. And fortunately, what we're seeing in Canada, and I've broken out BC, Ontario, and Quebec, is that in recent days, you know, any percentage growth is still exponential. But as long as this number isn't growing, it implies a flattening. And eventually, these numbers are the ones that start flattening and going down. These are the numbers of new cases on a daily basis. And you can see, like here in British Columbia, and I know there's a lot of people, I can hear you screaming through your screens at me, you're not following the right thing. That's a whole other discussion, but it's worth, you know, the question of what are you testing, who are you testing, and why are you finding new infections, and why aren't you tracking, well, any other number of things.
Horatio, we're going to get to that in a second. I just want to mark a date or two for people. I'm not sure, you know, I started, because all the days are blending together, I started keeping a coronavirus diary of what's going on every day. But just for most of the synagogues in Vancouver, we stopped having services. The first day we stopped having services was on the 16th of March. And the schools closed maybe a couple days later, maybe the 18th of March. So if you go back to that date, you're at 21% growth in Canada, and British Columbia, you're at 17% growth. So
well, that was an interesting day. That was one of the days where things ramped up very quickly. As you can see, you know, we went from 50 new cases to 83, 45, 40, 77. Well, suddenly when things got kicked into higher gear with respect to testing and who they were testing and where. But yes, right around then, that second week of March onward, is when things around here started to get very serious, and where all of these directives about social distancing were implemented.
Okay, so now I'm going to get you back to what you were saying, is that you can hear all the people screaming because they have Horatio. I think I forgot to say this. I meant to say this. Horatio puts these out with a discussion every day on Facebook, and they become quite popular, which is what brought me to say, wow, he'd be a great person to have on this conversation. And I know I wrote a couple times. I'm sure many other people said, wait a minute, they're only testing in the hospitals. So there are other ways of tracking progress. Do you want to speak about those and how
Sure.
you've looked at that data as well?
So as I said, like I started tracking this out of my personal interest and then put it on Facebook because I thought, well, this is a kind of a cool graph for people to look at and follow along. And at the time, what I was following specifically were new infections on the assumption that, you know, when we first, it feels like a lifetime ago, but it was not much more than a month ago that we didn't have these directives in place. And we were being told, you know, by Dr. Bonnie Henry that, yes, this is here now, but it's not, you know, it's not, you know, it's probably not a serious concern and most of us don't have to worry about too much about it. That started changing very quickly. My intention all along was simply to track what I thought was a reasonable and probably fair representation of how many new infections we're seeing, whether in Canada or BC or wherever else. You know, as time has gone on, clearly there was no mistake in understanding the fact that the intention was always been to flatten the curve and to implement these things so that we don't overrun our medical system. The measures these days that probably make a bit more sense would be things like hospitalizations, recoveries, how many people are in the ICU. So we're sort of reaching that point. You know, it's encouraging to see, especially around here, these numbers down here. If we keep these numbers up, and if we, you know, are able to sort of start to emerge back into the real world without affecting these numbers too badly, we're in a good place. And frankly, if we could draw a big circle around British Columbia, you know, close the border and close flights and all that, we'd already be there. That's not reality, but what we've done and continue to do and need to continue to do is exactly what we're being told by our health officials. You know, the social distancing is working. These numbers are working. And if you look at Canada as well, these are scary numbers up here. And that was only a couple of weeks ago. They've gone from 30s to 20s to teens to single digits down here. Same thing with Ontario. Same thing with Quebec. You know, these measures work. So to the extent, sorry, you look like I have a question.
Oh, no, I was going to just continue and I'll ask the question at the end of this thought.
Sure, I think so. The summary of that and what I've been trying to follow and is what is looking encouraging here. If you look at this particular chart right here, the thick red line is Canada. It's interesting to note the blue line of Quebec actually jumps over the Canadian line because initially, from the initial same starting point, they had a barrage of many cases. And they've, as you can subsequently see, started flattening that. Their initial time to double rate was about twice, like every 2 days. It's already crossed over the 3, it's heading over to the 5. As you can see, BC well crossed over the 5. And the fact is, if you look at, the thing about these logarithmic charts is that they sort of trail reality a bit by the nature of the way the data is charted. But a 2% case increase maps out to close to a month of time to double, which from an exponential growth point of view is, given where we were 2 or 3 weeks ago.
That's amazing. Do you ever track, some people suggest that fatalities per million of population is the most reliable back-to-back number. Do you ever look at that number?
I don't look at that number. And I think at some point I'm getting these days, as you might imagine, bombarded with you should add this and you should add that. And so I think at some point I will start adding some of those things as some of these sorts of numbers become less relevant.
Right.
You know, certainly here in BC, it's far more relevant, I think, today to be looking at how much pressure is being put upon the medical infrastructure. Right. You know, how many beds do we have and how many ICU beds do we have and that sort of thing. You know, we, as I said, we flattened it to the point of we're good. Now we just need to maintain what we're doing so that that doesn't shoot upwards. And then it becomes a very different discussion.
I want to point one thing out. People have been asking, where do you get your numbers from? And you can look at the top of his graph. He has the websites, World Meters, BCCDC, Ontario
And
page.
the you can use one has that one digs down into each province individually as well.
So yeah, these are publicly available. And the reason I wanted to point that out is I just think it demonstrates that you really, this kind of analysis can be very constructive. It can be a way to try and make a little sense of a scenario which is obviously very outside of much of our control. And there's a difference between doing it this way and refreshing your screen every 2 hours to see the new numbers. That's just sort of an obsessive compulsive activity. This is one which really helps you see the information, understand the information. But I want to transition to a sort of a second line of question, which is, Horatio, you have expertise in computers. And today, the governors of New York, New Jersey, Connecticut, Rhode Island, Delaware, they had a press conference that they're starting a commission to talk about reopening their economies, open their states to move out of this extreme distancing. And I've seen there are different models that are going on in certain countries. I think South Korea, Taiwan, they use phone apps to track everyone's. They use a combination of testing and phone apps to create an isolation scenario. And what's your sense, both in terms of the technology's capabilities and in terms of, let's say, Canadians were given the option of, okay, if you want to roam about freely, you want to open up your business, you want to go back to work, then go ahead, download this app and you're good to go. Do you think Canadians would be willing to trade privacy for freedom?
It's a really good question. I think that, well, I mean, here in Canada, we very much value our freedom. There's places in the world that's not really an option. So it's been, I mean, in a case like this, oddly enough, it's beneficial to be able to impose upon people, we're taking away all your freedoms for the greater good. I don't think everybody around here is going to be that happy having an app, having somebody up there know that you just came into close contact with someone that has this, for example. I think it's a bit of a can of worms. I'm not entirely sure that that's the direction that opens the world up properly. I think we need to get to a point where, number one, and of course the science is still a little bit open on this, but if we get to the point where, serology, antibody tests can tell you whether you've had this thing already, whether you're likely to be immune to it, and so have some sort of digital passport that you can carry around that proves that. That, I think, is sort of the direction that most people would be happy with, as opposed to, that's something I would certainly opt into, as opposed to a sort of a Big Brother scenario.
But based on your graphs, most of us are not going to be there for a very long time, because we're not.
Well, you know what? I think that if the intention was to sort of socially isolate everyone to the point that we can be comfortable by flattening the curve to the point where we know that we can handle this because we have the infrastructure in place, then it becomes a bit of a waiting game, right? Then really all we're doing is shuffling the deck chairs around until we have a vaccine. And at that point, all of this becomes irrelevant, because at that point, whether I had it or didn't have it, I get my shot, I get my booster, I'm immune, and I can get on with my life and I don't have to worry about it. So what we're talking about now is the sort of temporary measures to sort of get the world going again. Around here, I think, first of all, like I said, an immunity passport of some sort. If you're a shopkeeper and you know that you're okay, there's no real reason you can't go and start operating your business again. I think that kind of understanding is what's going to kickstart things around here.
Right. I, I maybe I'm not thinking this through well enough, but I'm just sort of appreciating the pain that so many people are going through, whether it's not having proper um, social scenarios for their kids, not being able to operate their businesses, not being able to do their work, not being able to go to school. That at a certain point, so we're a month into this, so a month has not been crushing, but I think as it goes on longer and longer, and one of the things that because we have so much less area under the curve, we have so many fewer people who have been infected here, assuming that that's the case, then we are theoretically well behind the rest of the world. So
It's one of these scenarios though where like it's a bit of a catch-22. We're here because we've done so well at doing it. We we've achieved what we've achieved by making what we can call a great sacrifice. So now the only question is how much longer do we have to do this?
right,
Arguably the answer is answerable in weeks, not months. We're 2 weeks away from this antibody test I was talking about. I don't know how they're going to roll that out, and I don't know who's going to have access to it and all the rest of it. But that's certainly the beginning of being able to have a classroom full of kids who are all, for the most part, immune, have had it, are not at high risk. The teacher has had it. The teacher can't be contagious. And it's not, until there's a vaccine, it's not going to be a one-day kick the door open and we're back to normal. It will indeed be scaled up. And given what we've done so far, BC is probably ahead of the curve in being able to start doing some of those things.
yeah. Okay, well, I really appreciate your coming on. I don't know if there's anything else that we didn't get to. There are a couple of questions here. I'll throw one or two out of. Here's one from. There's so many of some of these are very good for Gil as well, but is it possible that there's a false bottom, and really once we open up, we're going to let the floodgates are going to open, or is BC structurally different than one of these major outbreak centers like New York or Lombardy, because we're a very outdoor kind of place. We are maybe a society that has a little bit of that English operated as a distance sort of a scenario. There are just various structural or cultural things here that have just helped us flatten that curve. And so
you're absolutely right. There are a whole bunch of things that locally have helped us flatten that curve. But unfortunately, I don't know what they are. I think in hindsight, we might be able to point back and say it was the fresh, clean air, and the ocean breeze and lots of trees, and the fact that a lot of people already wear masks, and the fact that we are pretty good at following instructions. I don't know the answers to these. One thing I've heard is that the strain that we have here is a different one, that there's different strains of coronavirus floating around. And the one that we're dealing with is a less infectious one. The flip side to that is that we really can't afford to be wrong. So if we make some assumptions and we're wrong, then indeed what's going to happen is we're going to see an explosion of new cases, and we can't afford to take that risk right now when we're this close. If this was going to go on for 2 years, then it's a very different discussion, because by then the economy is destroyed. And I know that everybody is suffering. And it's one of these graphs that looks like this. At what point is the cost benefit, is the cost of what we're giving up worth the long-term benefit?
right,
That's a far bigger question than just numbers.
right. Well, because what's not on your graph is, what the survival rate with coronary artery disease looks like in 12, 18, 48 months, because those people haven't been able to see their doctors. And, do we get a spike in colon cancers because people haven't gotten their colonoscopies? And those are pieces of information that we can't track at the moment. And those aren't going to be available till later. But I'm sure what you can expect that in 2030, there people are going to write papers on that, because we'll know exactly how effective or how often people need to go see their cardiologist or their gastroenterologist based on this piece. We might also discover that a lot of people have less asthma because we have less pollution.
Exactly. And anecdotally, it's an interesting thing. I heard from I have a cousin in Boston who's a cardiologist, and he was telling me from experience, and he sent me an article, that the rate of heart attacks is way down. They're just nowhere near the number of heart attacks coming to the hospital. And so my question is obviously, well, maybe people are just afraid to come in. And in due course, we'll find out, are people actually having less heart attacks? Are they not showing up to the hospital? You would expect, under these circumstances and the stress that this is causing, that we'd be seeing a higher number. We're seeing a lower number. That's one smaller example of trying to compare apples to apples when you have too many variables to be able to figure it out.
Right.
I think certainly from my point of view, that was the whole intention of what I started was, I'm comparing apples to apples, just infectious rates mapped on top of each other. What does this look like?
Right.
And as time has gone on, yeah, there's 5,000 different ways to try to visualize what's going on here. And we will have perfect answers for all of this in about 5 or 10 years. For the moment, all we can do is make the best decisions we can going forward with what we know.
Horatio, I really, really appreciate your giving us this time, and your all the work you've done on Facebook and your insights here. Really really enjoy the fact that we got to glean from your wisdom and your hard work and your analysis. Now I'm going to switch over, as promised, to Gil Kimel, and we may be able to continue this conversation back and forth as we move forward. So I'm spotlighting Gil. Hi, Gil, and Debbie. Debbie wasn't here last week, so I wasn't 100% sure whether we can get Debbie, but I'm really glad that we have both Gil and Debbie here, both of whom are in internal medicine at St. Paul's Hospital. And Gil and Debbie read avidly on all of the academic papers published on this. And week after week, they've been the ones who kept us on top of things. So I know that there's some interesting things that you have. So I'm going to let you share your highlights. I just want to remind everyone that they can, people have sent questions. I've saved some of the questions for Gil and Debbie, but also you can either send them to me on the chat. You can also text them to Camille Wenner at 604-399-9423. I'll put that into the chat as well. So you can see Camille's number and text her if you wish. We'll bring her on for questions in a few minutes. But now it is my distinct pleasure to give you Gil and Debbie.
Hey, everyone, and thanks, Rabbi and Kimel and Howard, for setting this up. We're having a lot of fun doing it. I think this is our third or fourth time already. So thanks for tuning in. And I hope that is interesting and exciting for everybody. And like we said on the first session, every week there's new information. So what we talked about last week, there's some updates and new information. But I just want to know, how much time do you want me to talk, and how much time do you want me to do questions?
I'm going to give you 10 minutes right now. And then
Okay.
you have a couple of different questions. I think one of the most interesting, Horatio brought it up, but others have mentioned it, which is, do we here have a weaker strain in BC? And, what have we done right here to make this work so well if it's not a different strain? And what do you anticipate it looks like when we open the doors back up?
So I'll talk a little bit about the strain. So I was just reading about it today, actually. So this is from the CDC. So it is an RNA virus. So that means that it is very susceptible to mutate. But what they're seeing actually is that although there are some mutations, it may not actually increase the virulence or the contagiousness. And the reason why they're very interested in that is because there's no evidence now that if you're infected, that you're not going to become infected again. But because there's no evidence, they try to look back historically. So for SARS-1, which happened in 2002, 2003, people that became infected were not susceptible later on when it came back in the fall of 2003. So they're thinking that because the viruses are somewhat similar, that it's hopefully going to be the same features in this time. So based on the CDC's data, there are some mutations, but they're not making the strain, they're not making it more virulent or more likely to spread or more contagious. So that's a good thing. But having said that, remember what we said in class 1 was that this virus is extremely contagious, 4 times more contagious than the common cold. It has asymptomatic transmission, which is very different than what we see in Ebola or SARS-1. And the fatality rate is way higher than that for influenza, and it affects a somewhat different patient population. So I did get one email today when people said, well, it looks like Vancouver's not doing that badly. We only have less than 10 patients in the ICU between BGH and St. Paul's, or about 14. And so is this just like the flu? No, it's not. We do not want to become complacent or relaxed, because this is serious. And that will lead me into the next point, which is very interesting. And Tony Fauci was talking about this in the JAMA series. And he said, so somebody is at home. Oh, well, I'm assuming everybody know who Tony Fauci is, right? He's the
Tony Fauci is sort of the face of the science in the United States.
And he was one of the people that really started HIV research back in 1981, and is the head of the Immunology and Allergy Center, or Allergy and Immunology in the United States. But basically, in one of his interviews, which I think was from April 8th, he was saying that, so you have people at home, they get exposed, they have a bit of joint pain, loss of smell sometimes, develop fever, 39, we talked about 38, 39, and then all of a sudden, bam, they get short of breath, they have to go to get mechanical ventilation. So what are the risk factors for that? We have identified risk factors for who doesn't do well in the ICU, those with hypertension, COPD, and other medical problems. Diabetes also is a big one in Seattle, in the Seattle series. But why is it sometimes people getting fever and then they become cured, where sometimes people get fever, joint pain, and then bam, they require mechanical ventilation with very large bilateral infiltrates on imaging? So nobody's identified that, and that's a really important thing, and very different than other cases of pneumonia that we see, where people come into the hospital. I mean, pneumonia is one of the most common diagnoses that we see in medicine, and people come in, but they don't need to be intubated right away. They don't crash right away. And so nobody really knows that. And I think that in order to really develop therapies, we really need to understand the pathogenesis so that we can try to intervene and block whatever it's doing. There's some theories that, again, that we talked about last time, that it's a cytokine storm, and that leads to alveolar leakage, which means water getting into the lung.
Wait, stop a second. What's a cytokine?
Oh, yes. So a cytokine is it's an inflammatory cascade effect in the bloodstream that causes cell damage. And the interesting thing is that there's been papers written about why children aren't affected, and it appears to be that children's immune response isn't as developed yet, so their cytokine storm isn't as ferocious because it's just not there yet, and so that's why they're not succumbing to the disease as much. Whereas older patients seem to have unbridled control of their cytokine storm, and so that causes the leakage and ARDS, which is the most common cause of death for patients in the ICU, respiratory failure. So I thought that was really interesting. So I think that's one of the next steps to really get a hold of this disease before a vaccine is developed, is to understand the pathogenesis so that we can look for good targets.
I'm gonna interrupt and
Of course.
do something very dangerous, because I'm a rabbi and not a doctor.
Yes.
But if it was a cytokine storm, why don't steroids work?
Well, that is a fantastic question. So just yesterday, I was talking to my very close friend, Eitan Prisman, who may be online, I'm not sure. And he was saying, and he actually sent me a YouTube video about the series in New York where the ICU physicians are looking at it, and they're starting to reuse dexamethasone and ibuprofen, which were the two no-no drugs at the beginning in week 5 or week 6 at the beginning of February. So they're retesting this in patients in the ICU that aren't doing well, and they're seeing some good results. So is it possible that they're recovering on their own just because of supportive care, or is the dexamethasone having an effect in those patients that are really having a tough time? To me, it sounds reasonable that steroids would work. I mean, we always say, in patients in the ICU, you should always try steroids before you throw in the towel on anybody, because it's maybe some uncontrolled inflammatory response that's going to be controlled. And so intuitively, it makes sense that steroids would work, but at the beginning, there were some negative results. But let me just talk about one. So there's so much we can talk about, but again, I don't want it to be boring, and I want this to be exciting and relevant. So I want to talk about some things that are relevant from a public healthcare point of view. But just to touch again on this one drug, the remdesivir, which we talked about, it's a Gilead pharmaceutical drug, and there's a case series here from. Let me just look at where it was done again. I think it was the Italian study. And so they showed that 68%, and Horatio is he's the mathematician, so he'll really understand this and he'll want to comment too, but 68% of patients in the ICU that they tried, so 36 out of 53 patients actually improved. But so that sounds great, but it actually may not be, because you need to give a lot of patients this drug to have some response. So this doesn't necessarily, like when we see these that these drugs are having some response, can be a very specific patient population, those that are on mechanical ventilation that are really, really doing badly, and then they can recover with remdesivir. But it is not usually going to be a drug that's going to happen early on in the course of disease. And so I think that
you're saying it's a Hail Mary drug.
It might, well, that's what this study is showing, that in some patients it helps. But I think it's possible that maybe steroids works at the end stage, or maybe it works early on. Maybe it works before the patient, when the person first starts getting loss of sense of smell or some joint pain. Maybe that's the time to give it. I think, like also Horatio was saying, a lot of things need to be discovered. It's going to take years for this all to be uncovered, and I don't think there's going to be, an immediate response. But
the studies with steroids in ICU patients with sepsis, like bad cytokine response, inflammatory responses, were multi-centered studies, like followed forward for several years, and then many analyses later. And now we're trying to make answers with 60 patients. It's really hard to know if these drugs actually have an effect. Even if 68% did well, it's still a small number. And in medicine, we're used to analyzing things with that's going to show a significant result, and we often require thousands of patients to make those clinical decisions. So in order for us to change our practice, we're used to, as clinicians, to have very significant changes, results in studies, and it's too soon. We're not used to, as clinicians, to change our clinical practice based on these kind of numbers. So it'll be interesting to see how the medical community makes changes based on small studies with very small changes in the results.
But just on that, there are a lot of ICU docs and who are managing these things. How quickly does good information get to them? How do you, if you're really on the front lines of this, what do you trust? How do you know when to trust it? Like that must be a very difficult thing to do. Treating something you've never seen before, not knowing whether you can trust the information from, the Italian study or the German study, or how good anybody's data really is.
It's a good question. I think now there's little networks that have formed. So the Italians have had excellent data, and the group from Lombardy and from a couple of hospitals in particular in Milan, those are world-class ICU centers. And so I think, there's a bunch of papers published in JAMA. Maurizio Ciccone, he's one of the top people, and people are really looking to what he said. And their center was one of the first actually that tried, mechanical ventilation in the patient in prone position, like we talked about, because the lungs are better exposed and there's the better VQ match, which means that the blood is getting to the areas that can be ventilated better. And that's a really, really, really old technique, but it works. So they're doing that more, and they're doing it at the Jewish General in Montreal too. So I think the information is spreading fast. But I think if our listeners are really interested, what are the key things to get back to normalcy? What are we doing? Everybody's at home and wondering, well, when can this end? We're seeing good numbers, patients aren't coming in. But I think that the thing to remember is that the reason why the patient numbers in the ICU and our hospital are way less than we predicted is because actually people are behaving, and people are doing social distancing, they're washing their hands, they're starting to wear masks, and there's not as much congregation, and we stopped the large gatherings. And the one doctor that Debbie and I work with, Jake Onrod, he thinks that a big factor in BC may have been that apparently the Canucks didn't play at the end of February. They were on the road or something. I could be wrong on that, but he looked at the dates. Other than the dentistry conference where there was 15 or 16 patients and at least one person died, and also the rugby game, there wasn't that many large gatherings in that period at the end of February, which he thinks was a big difference compared to Quebec and Ontario, where they had a lot of Raptors games and Canadians and Leafs games. So that would be consistent with the data coming out of Italy, where they think there was hundreds if not thousands of people that ended up getting it because of that one soccer game between the Italian team, Atlanta, and Spain. I can't remember the exact thing, but it's published that that's where the super spreaders were. So I think that the reason why BC is doing well is because we're doing well, and because people are listening and we're getting the word out, and people are really wanting to protect our communities, not because we've been necessarily lucky, other than maybe the fact that we've had spring break later, which may have had a big effect compared to Ontario. But what are the keys to get back? I think that, like Horatio was also mentioning, and even I was talking to Andrew Merker today too, I think one of the keys is, and one of the lessons that we can learn is that we really need to do more testing. Because like we talked about last time, if we had an ability to test people fast, then we would know who's negative, and those people could get back into society, and those that were positive would just have to stay home. And if they got sick, they would go to hospital, but that would make a big difference. But I think that one of the things we could be doing better in BC is really using our testing facilities better. And I think that's really a lesson to learn. And that's really the data that's coming out of South Korea, which also Horatio mentioned. Like South Korea, Taiwan, and Singapore, those were really the countries to model after. So we've done some things like that, but we really would have wanted to follow in the gold medalists, if you will, for the countries that were ahead of us. We should have really been doing more testing, like South Korea, because then you can put people into different categories, and that would really make be safe. And also, the other thing I think that the really big lesson to learn is that we need to invest more in public health, and I think that that's really something that Taiwan did that was great. In fact, their hospitals had to be stocked for 3 months after SARS-1, so there was no shortage of masks, no shortage of N95, no shortage of gowns or gloves or anything, no shortage of training and hand wash. They had none of that, and none of their kids missed school because they were so strict at the borders that every person that landed or came in had a medical history and tracing and tracking. So it's really, what we can do better because the other thing that I'll say is that, so now we're seeing good numbers, but in the fall, this COVID hasn't disappeared. It's going to come back. And so what we want to see is that that we see a little surge and then it goes right down. But if we see a W pattern, that means that we're mitigating social distancing and then back. That's not good. But the way to avoid that is to have widespread, easily available, rapid testing. And one of the other things in the JAMA articles was saying, so there's the way that we're testing now is we're actually looking for the virus in the blood, in the sputum with PCR. But in the future, what we want to do is do serology tests and look for antibodies. But when somebody first gets infected, so for the asymptomatic transmitters and early infections, the antibodies aren't yet present. So you have to wait a few weeks for it to develop. But in the fall, that will be a good time to have the antibody test available, and it's very rapid. It takes just a couple hours, and it's handheld. And I think that'll really be the key to, as Dr. Onroth, Jake Onroth, who we work with, calls it squashing the curve instead of flattening it, is really getting rapid available testing available. And we've been really trying to appeal to the BC government about the science behind that, and we're getting some traction, but I think that's really the next step.
So Gil, okay, this is a very personal question, but so should I be writing Rosh Hashanah sermons or not? Should I assume that we're going to be together at Rosh Hashanah, or is that an unreasonable assumption?
Debbie, you'll take that one.
I don't think we can answer that question. I think just going back to, if we think back to what we talked about 4 weeks ago, and also a lot of the advocacy, both from the synagogue, from all the synagogues, the schools we've seen, and a lot of social media around physical distancing, it was about, the goal was to not overwhelm the hospital and the healthcare system. So we wanted to be able to have we want to flatten the curve, as Horatio talked about, less of an exponential rise in sick patients who would present to hospital, and then overwhelm the ICUs and overwhelm the ability to take care of patients. And we've achieved that, whether it was luck, whether it was good behavior, whatever it was, late spring break, we've achieved that at this point. But eventually, if we go back into society, we will have another wave, and we've seen that in other countries, and we've seen that with the 1918 influenza pandemic, where you had 3 waves happen. And so we, epidemiologically, we expect that there's going to be another wave. So how can we achieve to guarantee Rosh Hashanah services, guarantee an uninterrupted school year 2020 to 21? It's a very hard thing. I mean, as Horatio said, we live in a society that we want to have our confidentiality. We want to have our rights. We don't want to. It's possible we don't all want to get tested. It's possible we're going to open up our borders eventually. People are going to go back to work. What's the behaviors going to be like? So only time will tell if luck persists in Vancouver and British Columbia, or if we will have that second and third wave. But if we look back to history and how viruses behave, how this virus reproduces and how transmission occurs, chances are, we will have another wave. When that will be, hopefully we will have that sermon in the synagogue, but it's so hard to know, and we don't know how things are going to be because there's too many factors available out there. But one of the things, and a paper just came out of Quebec with their experience, and I agree with this, because we don't have proper treatment at this time, and we don't yet have a vaccine. Really, the only way to squash that curve, and again, in Canadian society, I'm not sure if it's possible, but is to do widespread testing and isolate based on the test results. And so that's the only way we can have that I can say there will be a likelihood that we can resume society without waves of isolating and then going back into society and then going back to isolation and then going back to society. But I don't know if that's possible based on the Canadian how we are as Canadians and our own confidentiality and our own rights, if we'll buy into widespread testing.
Well, I'm going to go to Kimel.
Can I just add one thing? I think
I can't have the final.
Just one thing. So I think, with respect to, let's say, so we're back in shul, I think that things will change. I think that maybe, we won't be handshaking. We won't be, if we're sick, we'll really have to be responsible and not come to shul, and certainly not sending our kids to school with a cold. If you have a cold, stay home. I think we have to be really strict with that and monitor each other, because we know that this virus is more contagious and this is not just a common cold. So I think behaviors need to change, and I think that'll go a long way. And again, if we increase our funding in public health and helping society really understand how to mitigate this, then I think that'll really go a long way. But I do think behaviors are going to change in the future.
Okay, there's so many questions, but I promised Kimel that we would I promised people that we would go to questions, and I'm going to move to Kimel to ask some of those questions.
Hi.
Hey.
So a few questions, I'm just scrolling up here that I marked down. Studies by German epidemiologists show, while of course the virus is very contagious, that it seems to occur from contact which is not casual and not from touching surfaces such as grabbing the bag on the at the grocery store or at the checkout counter at the grocery store. What are studies showing now in terms of like contact?
So yeah, I think for sure for healthcare workers, the most common mode of transmission is hand to face. So people are touching things in the hospital or touching contaminated surfaces, but it's not being coughed on directly. That I think is pretty well established. And there was an interesting discussion about, how come, I want to just make sure I got the cities right. So New York, Paris, and London had a very different experience than Tokyo and Berlin. And they're very similar cities in terms of apparently their metros, their subways, and also their density. But yet Tokyo and Berlin did quite a bit better. So why is that? Nobody really knows, but originally they were thinking that the reason why New York was having such a tough time was because of the subway. Now, I tend to think that that's really the case, because that New England Journal of Medicine study showed that the virus lives on stainless steel surfaces for for up to 20 hours. And so I thought that was really, really important to take notice of. But nobody knows really 100%. But I think again that the chance of being coughed on is a lower risk of transmission in doing your daily activities.
I mean, if someone coughs on you and they have COVID,
That's
of course,
bad.
that's bad. But the behaviors have changed unless someone's intentionally trying to cough or spit on someone, which we've seen this in social media. But definitely, that's why we say hand washing, because if you touch a surface that has COVID, the coronavirus on it, you're okay as long as you wash your hands properly and don't touch your face, right? So grocery shopping could be safe if it's done with good physical distancing and washing hands after touching surfaces.
And wearing masks. We're big proponents of wearing masks, not necessarily to protect yourself, but to protect everybody else. Because if everybody wore a mask, then the virus would really, really have a tough time transmitting. And there's been so many questions about masks. We can save that for later. But if there's any questions about masks, because I brought different kinds to show people, because you may have noticed. Jake Onrod, myself, and Val Montessori, we wrote a very short editorial in the Globe and Mail last week about masks. So we're really trying to appeal to Health Canada that after they told people to wear masks, to actually tell them how to put it on, how to care for it, and why they're wearing it. And so we're a little bit disappointed that that second part wasn't included. But we're at St. Paul's, we're definitely very big believers in masks from a societal point of view. And last night we were actually watching an interview by this person who I'd never read anything from him before, but his name is Frank Snowden. He's a history of medicine professor at Yale, and he happens to live in Italy. And just in the fall, he wrote a book about pandemics. And he's in Italy now, and he's saying that in Italy, if you go to the grocery store, people that aren't wearing masks are being asked to wear masks. Like they're being pointed out, because society there is very aware that if everybody wears masks, the rate of transmission will really plummet. So I think that the science is there, and when I see people in the grocery store wearing masks, that makes me very happy.
Great, thank you. Another question in regards to the opening of non-essential businesses in the near future. Would it not be possible, do you think, if certain businesses were granted the ability to reopen with using the proper COVID protocols that grocery stores are doing? So, making sure that carts are cleaned, that there's hand sanitizer, people are wearing masks.
Mm-hmm.
Do you think we see that in the near future, just, on a economic level, to help, businesses continue to run and for our society to continue?
Well, I mean, I'm not an expert in public health, but let's imagine this. Let's say if everybody was given an appointment of when they could go to whatever store they wanted, then obviously the rate of transmission would be low, because you're monitoring who goes in and people aren't near each other. So the risk is in high dense places where you have a lot of asymptomatic transmission, which is much more common in younger patients. That's the hypothesis. And that's why, again, large gatherings, sporting events, weddings, and those types of events where people are exercising and sweating and cheering and breathing or whatever, doing those kinds of activities, that's going to be high rate of transmission. But if you're calm going into the pharmacy and you're wearing a mask and you're washing your hands before you put your mask on and when you take it off, I think the risk is low. So does that mean that we're going to the grocery store every day? No, we're making a list now. We're trying to be a little bit more proactive, and Debbie's in charge of our food, and she's been doing a fantastic job. But going to the grocery store only when we need to, and so I think that's good. That's good behavior until this thing cools off.
But it'll be public health, obviously, to make that decision. But when it comes, as Bill said, our behaviors are probably going to change for the next few years. And Dr. Fauci actually talked about that in his last interview, was saying how, we're not going to be shaking hands. We're not going to be kissing cheek to cheek as much anymore. And similarly in the workplace, when like non-essential workplaces or parks open up, they'll probably be, if we continue to have good behaviors until we have vaccines in place, et cetera, then I think eventually public health will open up these spaces. But it won't be I don't think it'll be as it was pre-pandemic.
quick question. There's a testing site at 33rd and Willow. One of our individuals who's lives nearby, one of our members, is wondering. She said it's often very empty in there. Why are they not testing more people? And what is the holdup? Like, why can't they open it up a little bit?
Yeah.
But I mean, right now the testing is there, I believe, is restricted to healthcare workers who have symptoms. I think it's for healthcare workers. Yeah, that's where we're told to go or tell our colleagues to go if they have symptoms. So if you're asymptomatic, you can't get tested at this point.
Which we don't agree with, by the way.
Yeah. So that's the site there.
And I would assume that site is also for physicians, healthcare workers who unknowingly come in contact with a patient who then tests positive.
I'm not positive about that. I can't say for sure. That would go through our infection control person, and then they would make the decision whether we're like on the record. We do things based on the public health suggestions, but we're always told we should use our clinical judgment, clinical acumen as well. So it would make sense to me that someone who's what we've been doing for people who are exposed to someone is the same thing that public health suggests, is stay home. So if a healthcare worker is exposed to someone with confirmed COVID, they're not allowed to work, whether they are positive or negative on a test. So they have to stay home.
Right.
Isolate. So they wouldn't be required to get tested.
Right. Great. Everyone wants to know how to put on a mask.
Okay, perfect.
Properly. Please.
So let's do that. So now just a couple of things, and I don't know if Dan Robibo's on, but we've talked a few times about masks, and he's really up on the literature too. But not all masks are created equal. But if we're wearing masks to protect others, then whether you wear a cloth mask or a surgical mask or an N95 is going to be very similar. If you're wearing it to protect yourself, that's when different masks are different. So let me show you some samples, because I'm getting a few emails a week, and some of them are from our guests, our listeners, about how can we help, and they want to give us masks. So these are the masks that we want, these ones right here, and they're very hard to find, but these are like the N95s, the medical version, NIOSH tested, and you'll see the ones that you get at the hardware store are not usually blue, because this blue covering is a waterproof barrier, so in case they're splashing, whereas carpenters don't need that, but it's still an N95. So how do they actually work? Well, people think that it's actually that the virus is unable to pass through, but actually this is a polypropylene material that is electrostatically charged, and so it repels that size of virus. So that's really the interesting thing. And so what people were doing was they would wear it and they want to reuse it, so then they would wash it with alcohol or bleach. Well, that is really dumb, because it takes away the charge on the thing. So you don't want to wash it. And because the studies show that the virus only lasts for a few days, now this one happens to be a new one, but if you just left it face down for a couple of days, then the virus is going to die anyway. So there's no need to wash it. There are some studies that show that hydrogen peroxide is safe, or UV light. There's all kinds of things that people are just depositing them back, and then they're purifying them for anybody to use. But if you just have a few on your own, and I've been using the same one when I go to the grocery store, I just take, so step one, I don't use this one, and we'll explain the difference, but step one is always hand washing. So if you're going to go to the grocery store, you need to have some kind of alcohol wash in your car, because as soon as you go into your car and you touch the door, your hands are contaminated. So you need to bring something with you, unless you put on the mask at home, but assuming that you want to drive without it on. So then you wash your hands, and I'll demonstrate a full thing here in case they're videoing this. So you want to wash your hands.
Between your fingers.
Yeah, or with soap and water if you have a sink in the back of your car.
I didn't see you sing happy birthday.
Yeah, well, the alcohol.
You don't have to with that.
The alcohol you don't have to, because but the thing with alcohol is that do not wipe it on your pants, because the whole point is that it dries, and that's how the virus is killed, or bacteria too. So this is a surgical mask, and the surgical mask is really designed from things that are coming out of your mouth. So it's not actually preventing things coming in, but it does a pretty good job. The barrier, if there's somebody coughing near you, it's not as good as the N95, but it's still very good. But when you put it on, so I've seen everything. I've seen people wearing it inside out with the blue strip on the outside. I've seen people wearing it upside down with this under the chin. I've seen people wearing it only on their mouth and not their nose. Those are all useless. If you're going to wear it properly, you want the white side. Most masks on the inside are white, and the outside is blue or white, but usually blue. So you want to put it on, and the way I do it is, for this one, the surgical mask, is you kind of untuck it a little bit and you put it on and put it over your ears, and then you position it first by pulling the chin part down and then using both hands, smoothing it around your nose, and that's it. So once you put it on, you don't touch it. You go into the grocery store, go into the pharmacy, do what you need to do, put the stuff in your trunk, and then before you take it off, you want to wash your hands again, because your hands are contaminated, because you may have touched, you know, the door handle for the yogurt or whatever that's contaminated. So when you take it off, you have to wash your hands again, and you have to assume that the outside of it's contaminated. So I just take it off very carefully like this, and I just leave it in the back of my car, and then I don't touch it. And I have 3 of them, and I just recycle them over and over again. And it's way more than 3 days, because we're not going to the grocery store every 3 days. So I think that theory makes sense, that the virus is going to die by itself, but I'm not washing it. I'm not putting any bleach on it or chlorine, because I really want to maintain, especially on the thinner ones, which also have some electrostatic charge, but it's a very different mechanism than the N95. I just don't want to destroy the fibers if they're actually providing some protection. So this is so people have these, we will gladly take them, the 3M N95s, or these, which is actually the one that I was fit tested for just this past Wednesday. So I think this one is actually the best. It's called the Aura, for my face, the 1870 Aura. 3M people, these are really the top notches. Now, usually they're like 60 cents a piece, but now they're selling for $10 each. And the other thing that we've been seeing, and I've been in touch with the CFO of our hospital, is that there's a lot of ones that are not actually real 3M, and they're replicas, and there's these things they're calling K95s and things. None of them are as good as the original 3M 95s or the Honeywell ones that are made with a plastic elastomeric piece on your face. But
you don't need those ones for going out. The masks they talk about are
surgical masks, or homemade material ones. But what else? Oh yeah, the other thing that's very interesting. So
the question was around masks.
Yes, this is about masks. So the Hanes company in the United States, which is the underwear maker, as well as Stanfield's in the East Coast in Canada. So they can make masks out of that cotton, cotton underwear material, and they can make hundreds of thousands. And I think that'll be really good if we can get masks out to people for free. That investment by Canada will go a long way. If everybody could get a few masks, if families could get easily affordable masks, I think that would really make a big difference from public health. And if we had a little video on public TV, how to put it on, how to care for it, and if it's made out of cloth, it's easily washed, I think that would really go a long way to help people, because we know that you're limiting your ability to spread it if you're wearing a mask. What else do we have about masks? I think that's it about masks. And if we can take some more questions, and if not, I have a couple of other little tidbits that people may find interesting.
Just one. It was quite a while ago, but there are 2 questions I'll sort of roll into one. One is hydroxychloroquine. Saw there was some cardiac issues. There was someone on the chat mentioned that there was a French study that had 94% success rate. Update us on that, and as well, if there are different strains, or there are different approaches to the different strains.
Okay, so for the hydrochloroquine, which is the one that Trump touted, so there's that French study was not properly powered. It wasn't randomized, and the virology world has always had in vitro studies. So it means that you have a virus in the lab. Hydroxychloroquine has always shown to have some effect on viruses, but it never works in patients. So nobody's really surprised that it's not working in these patients. So if you ask me, I do not think that it's good for treatment that have advanced disease, but maybe it's good for people that have very, very early disease. Because we know that one thing interesting about COVID is that probably the dose makes the poison. People that have very high exposures, very high viral load, seem to get sicker, which is different than other diseases like TB, where you get 1 particle or 1 million, you're going to have the same course. So there may be some truth if you catch it very, very, very early on and try hydroxychloroquine, but there's no studies. So the bottom line is I would not take it. I would not buy it. And the main reason why I wouldn't buy it, which Debbie and I discussed, is that it really limits the ability of patients that really need it for proven diseases like lupus to get treatment. So please refrain from buying it, because we want the patients that really need to get it. And if in the future there are studies that show that it really helps, well, then the labs can really ramp up and produce a lot and will have it available. But up until this afternoon, I have not seen any conclusive evidence that it's helpful at any stage of disease.
It makes like some pathophysiologic sense to me, like Gil mentioned, that maybe early on in symptoms, with a low viral load to try and squash the infection in that person, maybe it'll work. But again, we don't have the studies, and at our hospitals, we are not using it. And the other question, you asked another one.
Was the different strains, different approaches?
Yeah, I think so. Again, just the latest thing from the CDC was that because it's an RNA virus, we expect it to mutate, which means that it changes, because it's like a bad speller. So they have all these amino acid codes, but whoops, one of the codes can be switched and the virus changes a tiny bit. So that's how viruses become more virulent, like when it went from the bat to this animal called the pangolin, which people have seen, maybe seen the article in Nature, which showed that it's no longer, they think it's a snake, but a pangolin, which is an animal that I never heard of it before I Googled it, but it looks like an anteater with kind of like scales on it. And you guys can all Google it on your free time, but that's what they think they were eating, that animal, and that's how it mutated in there, because the virus is the RNA is so unstable that it can just change to be more virulent. But from a clinical point of view, it looks like although the virus is mutating a little bit, it's not making it more or less harmful. And so again, if it goes down in the summer, which by the way actually is showing some promise, because although there are cases in Australia, it's not as bad, and also in Mexico. Now it's possible that they're just not testing it properly, but it looks like the hotter climates that have the ability to test and are tracking mortality. So hopefully it will go down in the summer. We're really, really hoping that it will. But if and when it comes back in the fall, we're hoping that there'll be some immunity available. And again, I think that the main reason why BC is doing well is because we had some advance notice, people started social distancing, and they really did a good job. So we don't want to lose that enthusiasm, but we also want to get back to work. So we want to have a good balance, and we don't want it to be sawtooth up and down. We want to squash the virus, and continue to do a good job. Oh, we lost this.
Yeah. I want to thank you so much for giving so much of your time and expertise to us. Really, really value this. I think I can speak on behalf of everyone. Also want to thank Horatio again for his contribution to tonight. I think it's really been an excellent discussion. I love the fact that people come in with so many questions, and I love the mask fashion show. I just want to, Debbie, you are confirming that for individual use and protecting other people, using your mask to protect others, a cloth mask, a homemade cloth mask, a buff, or what do they use for like skiing, the balaclava, all those things are effective at mitigating yourself as a spreader.
Yes.
Yeah.
There is some studies. I mean, Dan Robibo, I think, is the expert on this in our community, and there is some studies that look at all the different cloth, different fibers, and have like how effective it is compared to an N95 or to a surgical mask. But anything that you wear is helpful if you're coughing, especially. So we want to really, from the asymptomatic transmitters, those that's one of the main problems with this disease, is that people have it, they don't know it, and then they spread it. So if they're wearing a mask, then they will reduce the spread.
So I think the same theme that we've been saying: if you are sick, if you're coughing, if you've got a runny nose, a cold, stay home. And if you are asymptomatic and you're going to an essential place or to a walking outside, continue to physically distance, wash your hands if you're touching surfaces before you touch it, to protect the surface for the next person. Wash the hand after you touch the surface to protect yourself from the surface. And if you have a mask, wear it in case you are an asymptomatic carrier. So it's in the end, it ends up being common sense, but I think the behaviors have been changing in BC, and they have to continue to change to protect, especially the vulnerable people in society from getting this infection. So yes,
So,
masks, we encourage them.
So I just want to conclude with two things. One is maybe our next session looks like the right date would be the 23rd, 10 days from now, because we still have Passover. It'd be hard to do next Thursday. So the 23rd, I'm hoping, is our next one. And I'm going to give you a little bit of a research project. How is Israel doing? And what are they doing that might be different than other places? So because we're getting close to Yom Ha'atzmaut, I think it would be nice to do a sort of an Israel slice of this particular question. On the also moving from Israel to something which is particularly Passover related, because this year we're not able to do Yizkor on Thursday as it would normally be. We're going to have sort of an attempt to approximate Yizkor. We have given and we will continue to give out materials for people to do Yizkor on themselves on Thursday, which is certainly appropriate. But we're going to, the Cantor and I are going to be hosting essentially a Yizkor session tomorrow at 10:30 for those who wish to participate. We're hoping to make it a meaningful service. We're hoping that it will have at least sort of the feeling of having been at least the approximation, if you will, of having been at a Yizkor service. And invite everyone to join us for that. Also, just want to thanks to Kimel for providing great support throughout the synagogue. Also, just a special shout out to Rachel Lewinsky and to Kimel, but most especially to Rachel. We delivered enormous numbers of Seder in a box. I don't even know what the number is anymore, but we were featured by some of the local media. It was a very touching story, and there were lots of people who were very positively impacted by your donations. I mean, the community in general, but also the hard work of Kimel and Rachel Lewinsky. And also just want to give a shout out to Howard Kollner, who's really been a fantastic leader in this effort to keep the synagogue alive, relevant, and touching people's lives. Really tremendous kudos to him for all of his good work as well. I want to thank everyone for joining us. It's been wonderful to have you. It's been wonderful to see everybody's faces, and I hope everybody stays safe, has a wonderful Pesach, and I look forward to seeing you physically soon.
Thanks, Rabbi. Thanks for organizing this, and thanks, Kimel.
Thank you.
Thanks,
Thank you, guys.